Oh, here. Okay. So by my phone, it's just 6 p.m. now. We'll give it till 6:02, and then I will get started with the presentation. Okay, to everybody that's online, thank you very much for attending. A note was just sent out to just remind people that we are recording these webinars. So if you do not want your gorgeous faces on the tape, you can hide. Although I think, for me personally, I actually like to see people. I see some names from Princess Margaret of patients that I knew when I had my work there, so I'm thrilled to see some of you. Just a bit of housekeeping. Please keep yourselves on mute. Sometimes people forget, in the background noise with kids and dogs and husbands and garbage trucks, etc., makes it difficult for other people to hear. So tonight is quite different. Our beloved Dr. Donna Reese is having this webinar off. Dr. Reese has been primarily presenting the science between myeloma and the treatment of myeloma. There have been some requests to address things like palliative care, symptom management, and medical assistance in dying. I recognize that these can be very difficult topics for people. And we will have a Q&A at the end. If there is something that you're not comfortable talking to me or asking questions in front of the group, you can email me at my CMRG email, and we can arrange to have a chat privately. Again, death and dying is a touchy subject, regardless if you have an illness or not. And certainly in our culture, we don't chat enough about it. In my humble opinion. Slide, please. So the goals of the series have not changed. Dr. Reese and CMRG and myself, we want to continue providing both scientific and patient-oriented perspectives about myeloma features and biology. We want to hear from you in the audience. Anything you'd like to learn more about, please let us know. Always remember that all of the seminars are on the CMRG website, and you can always access those. We really, really want to ensure that patients with myeloma and their families and loved ones, you are the stakeholders, and we want to have this forum as somewhere where people can ask questions and receive answers that can be helpful or help guide. Sometimes guide the questions that you may ask in your clinic appointments. Slide, please. So I've talked previously about the symptoms that that patients that are diagnosed with myeloma might experience prior to being diagnosed or just when they are diagnosed. Tonight, we're really talking about symptoms that myeloma patients uh, may encounter. Not everybody is going to have all these symptoms. They may come and go, depending on where they are in their disease trajectory and what treatment they may be on. But I think it's important to recognize that having multiple myeloma or any serious illness, it really does ebb and flow. And I think it's crucial for people to understand that for every bad day, you're going to have a good day as well. And just because things change and you wake up one Monday morning and something, you've got a new pain, or you're just worn right out, and things are really quite manageable in most cases, and it's unlikely to last forever. I think fatigue and weakness of all the years that I was in practice and primarily in symptom management and palliative care, it was fatigue that really, really bothered patients the most. Because unfortunately there is no magic pill for fatigue. We have many people have tried to figure it out. There are certainly strategies that can be undertaken. But I always have said that we all need to listen to our bodies, and when we've been knocked down a peg or two, to really listen and just take a day or so to regroup. The old saying, no pain no gain, we know now that was a really dumb thing to say in the 80s. It's not true at all. You really need to listen to your body. Bone pain and fractures, obviously, this will cause pain. I talked a few months ago about the importance of letting your team know if suddenly you have a new bony type pain, because myeloma patients are certainly at risk for fractures, and those things need to be addressed. Frequent infections, we've talked about the importance of ensuring that vaccinations are up to date, that hand washing, again, we all learned a lot during the pandemic, and to work with your team to ensure that your myeloma patient or yourself as a myeloma patient, the immune system is as strong as it can be, whether that's using prophylactic antibiotics or immunoglobulin infusions, etc. Constipation, often constipation is caused because we often use narcotics or opioids for cancer pain. And I'm going to talk about that in a second. But constipation is very manageable. You just have to, be on the right track on how to manage your bowel pattern. Kidney damage. The one thing again for kidney damage, to prevent kidney damage, Patients with myeloma should never use NSAIDs, things like Advil, ibuprofen, contrast dye for CAT scans, because those are excreted through the kidneys, and we want to protect our kidneys as best we can. Increased thirst or urination, something that you should report to your team to ensure that kidneys are functioning properly and that blood sugar is also where it should be. Numbness and tingling in hands and feet. Anybody that's been on Velcade over the years, we know that Velcade or bortezomib, one of the side effects can be neuropathy, where you get tingling in hands and feet. Again, something that's very important to report as soon as it starts, and not be a tough guy or a tough girl and think, well, I don't want them to change my medication because it's working. And patients are often afraid to report new symptoms, because they tell us that they were afraid that we will, stop treatment, etc. Confusion or decreased alertness. This is something to really talk to your loved ones about, that loved ones should really be aware of this. This could be an indication that there really is something wrong, and something that needs to be investigated. And I know that we are not always our best we're not the best person to make those assessments. When someone is befuddled, whether it's after surgery or they're heading into dementia, we often don't see it ourselves. So confusion or decreased alertness, really can be a medical emergency, and should be addressed. Slide, please. So I don't have enough time in this hour and a bit to really go on, what medications to use for what symptoms. Um, we have talked about that in previous presentations. But the most common things that we really see, again, one is pain. And pain can be something that's ongoing. People that have had vertebral collapse or fractures in their spinal cord secondary to their myeloma or from osteoporosis, that can be a chronic type pain, even post kyphoplasty. If there's a new acute onset of pain, especially in the hip or the back, certainly needs to be addressed. And if you're in an area where you're not going to see, the myeloma patient isn't going to be seen in clinic in the next little while, this is something that should be, nobody wants to go to the emergency department, but the patient should go to the emergency department, because if there's been a new fracture, the sooner it can be managed, the better. For instance, if you have a new hip fracture, and as a myeloma patient, you don't have to fall. I mean, you could just sit down hard and fracture your hip if you've got bony involvement in that area. The sooner it's addressed, the less likely you are to need a total joint replacement, which is a big surgery. What we do with hip fractures that aren't very, very complete is we use radiation to sort of spot weld the area, if you might. So the sooner you report any new or different pain, the better it is. Again, talked a little bit about neuropathic pain, especially for Velcade, patients that have come from other countries that have been on thalidomide in the past. The literature shows that up to 75% of patients with myeloma will experience neuropathic pain at some point in their disease experience. As we know, the actual myeloma can go anywhere. If you sort of think of it as a sticky substance, and again, I'm not the scientist in the group, but it can actually sit on nerves. I mean, it can go to your kidneys, it can go to your bones, it can go anywhere, but it can actually sit on teeny little nerve endings, which will cause this neuropathic pain. patients that have had other cancers or that have secondary cancers, and they're being treated with alkaloid agents such as cisplatin or vincristine, which we don't use for myeloma, they often have quite severe neuropathy. So it's important that it's addressed, especially in neuropathy in the feet. It's very, very much the same as patients with diabetes, and they'll have this numbness and tingling in their feet due to the diabetes. And if it's not looked after, especially if you're out for a lovely walk and you get a little pebble in your shoe, if you have neuropathy and you don't have normal feeling in the bottom of your heel and there's a pebble there, it may actually end up with a really serious infection because you didn't feel that pebble, and you just thought, well, I always have that weird feeling in my foot. So it's important. I always told patients to, just like people with diabetes, patients with myeloma, if they have neuropathy, they really, really should do a really good foot inspection at least every other day to make sure there's no new open areas. There's no new injuries. Don't go to the nail salon for that. Do it yourself. Nail salons aren't necessarily the best place for anybody who is at risk for infection. Belly pain, abdominal pain, can be quite common. Constipation is the number one culprit, usually secondary to the use of narcotics or opioids for pain. Um, the other thing, though, is that if you're someone who isn't sort of getting quite routine blood work and you haven't been feeling well and you have abdominal pain, you might want to let your team know and say, maybe we should have my calcium checked, because elevated calcium will actually one of these signs can be abdominal pain. The other thing is that a lot of you are likely on a fair amount of medication. And most medications, is as simple as plain Tylenol, can be irritating to the gut. And we want to make sure that whoever is the prescriber is working with you to see, we don't want anybody to have abdominal pain and nausea secondary to medication that's supposed to be helping you. So don't ever think, well, Dr. Bob there, he wants me on this medication and I'm just going to sort of suck it up. And quality of life isn't that great when you've got abdominal pain, because most time 90% of the time we can switch things around or use other medications to sort of manage the GI irritation. So it's important. Again, pain, neuropathy, abdominal pain. Not everybody's going to get this, and a patient might have myeloma for 19 years and never have any of this, and that's fantastic. But it's good to know that if these things do come up, okay, we should make sure that this isn't something going on with my myeloma because it's new. Slide, please. Again, repeated infections. I don't think any of us that in the biz, so to speak, can reiterate enough how important it is to ensure that anything that can be done to avoid infection is very, very important. At the same time, to not ignore symptoms of an infection. And I've said before that, if I, excuse me, if I was exposed to someone who had, a upper respiratory infection and I caught the bug, I'm pretty darn healthy. I would fly through more than likely. But if you're a cancer patient of any sort, and certainly myeloma, because we know that patients with myeloma, immune system is never as good as it was before the myeloma showed up. That your friend's cold could easily become a serious pneumonia. So to not address things early on. And I know I've mentioned before, patients would come in to see me in clinic, and they literally just be dragging, or they'd come in a wheelchair when normally they were walking. And I'd find out that they were sick for the last 3 days, but they didn't want to go to emerge, and they didn't want to bother anybody, so they were just waiting for their routine appointment. And that's when people get into trouble. Patients with myeloma are at risk for serious infections, and you should never, ever, ever mess around and just sort of ignore it. And all the chicken soup in the world isn't necessarily going to fix it. So fatigue, again, over the years, I think this is the thing that patients expressed to me so often, that it was just really quite unbearable, to not feel like you're able to lift your head off the pillow, and not able to do, your normal fun activities, whatever it is that you like, whether it's golfing or visiting with grandkids or riding a motorcycle, whatever it might be. And very, very, very frustrating. Occasionally, it is due to low counts, and we've talked about low blood counts before, and what they mean, and what we can do with transfusion support, etc. But even patients with a decent hemoglobin often will just have this really, crippling fatigue. Um, Very often, what happens when people have got cancer fatigue, um, eventually they end up in a depressive um, situation. And I want to ensure that everybody online understands that a reactive depression to a situation, such as having a serious illness, or you've got a child that's in trouble, or you have money issues, those are reactive depressions that will eventually go away in time, but they still should be treated. Again, we only have so much time on earth. Some people live till they're 90, some people live till they're 55. You want to make the best out of every day that you have. And being low and depressed, and not interested in family and friends, etc., it's not necessary. It's really not necessary. And it's not shameful. It really is not shameful to admit that you're really, really struggling. We know that women that have had postpartum depressions are more apt to have a reactive type depression, or an onset of depressive illness down the road. Very often, a short course of antidepressant medication can be helpful. And there's one particular medication that I would prescribe all the time, because it really covered a lot of the bases for patients. It helped with depression, it helped with anxiety, it helped with sleep, it helped with appetite, and people felt a lot better. But probably 4 times out of 10, patients were always very reluctant. Well, because there's some sort of stigma about being on an antidepressant. um, Anybody with a life altering illness has every right to have a little bit of a pity party, as the kids would say. This is not what we expect in life. This is not what, we don't dream when we're 25 that, well, when I'm 42, I'm going to have this really weird illness, and I'm going to have to go to hospital all the time. It's a lot. And your team can be very, very helpful. And if your physician is not comfortable talking about these issues, then you ask, say, I want to see someone in psychosocial oncology, whether that be psychologist or psychiatrist or social work, or a nurse practitioner that has experience in these areas. Hematologists that are treating myeloma, goodness knows they're brilliant and important, and but they're not always that comfortable talking about these more personal things. With fatigue comes changes in things like sex drive, and having an illness is hard on any relationship. But when, the patient, not only are they worried about what's going to happen, they also just can't even imagine being sexually active. It can be really hard. So don't ever be ashamed. Mentioned a couple of slides ago about confusion or changes in normal mentation. Sometimes new medications that are introduced can sort of knock the brain a little bit, and sometimes things will need to be tweaked. Maybe the dose needs to be lowered. Maybe it's not the appropriate medication for you particularly. But don't just sit there and suffer. I mean, if your spouse has got myeloma and he or she's been prescribed ABC medication, and all of a sudden they're just not their normal self at all, don't think, well, we just have to put up with it. Absolutely not. Absolutely not. It's certainly something that should be, brought up, and probably not wait until the next clinic appointment, but to, call out whatever numbers or however you get in touch with your team and say, listen, she or he started this medication 3 days ago, and they're not themselves at all. Sometimes low hemoglobin can certainly make you feel a bit befuddled, excuse me, and confused, remembering that oxygen is carried on hemoglobin. And if your hemoglobin is low, you're not getting a lot of oxygen to your brain, or you're getting decreased oxygen to the brain. So, your brain, your whole body's having to work much harder than normal. Stress. I raised boys. They were teenagers once. Stress is a real thing, and it can really, really mess with you. And also poor sleep if patients aren't sleeping well. And you're sort of getting 3 hours here and 2 hours there, and you're not getting into a decent REM sleep for whatever reason. Maybe it's pain, maybe it's anxiety. This can absolutely add to changes in normal cognition. So those are certainly a lot of things to be overwhelmed about, without a doubt. Again, I reiterate that not everybody has every symptom. By the grace of whomever, we hope that many of you go through your journey with myeloma without getting into much difficulty at all. But it's important to know that it could happen. And it's important to know that there are things that can be done, whether it's psychosocial support, whether it's medication, whether it's a change in medication, etc., that can help. Slide, please. So again, almost all of these symptoms are quite easily managed. But if we as prescribers don't know what patients are going through, we can't fix it. And I've heard, it was really interesting as a nurse, patients would tell me things, and I'd say, well, did you tell Dr. Reese, or did you tell Dr. So-and-so? Well, I didn't want to bother her. She's so busy. Which I sort of found a little amusing, because, they want to know. They want to know. And so, don't keep things to yourself. Say, listen, I'm not comfortable with this, or I don't understand this, or, I've got this pain and it's changing, or, Bob, my husband here, is not himself. There's again, almost every situation is manageable. I have to, we talked about constipation often being a cause of narcotics, or opioids being a cause of constipation. The last 20 years, opioids, narcotic medication, has had a really bad rap, and rightfully so. I mean, there were some very bad things that happened, and we have many very, very sick and very ill people that have become addicted to opioids, specifically fentanyl. But opioids are absolutely appropriate for patients that need pain management. If you have 7 fractured vertebrae in your back secondary to myeloma, I don't think a couple of plain Tylenol is just going to do it and make you feel better. And the science is very, very clear that if we're using pain medication because we're having pain, it doesn't make us euphoric. So we don't get high because it's actually dealing with the pain that we have. Patients that their pain is resolved and they keep taking the medication, that's when they get into trouble. But, there are many, many, many patients, specifically with myeloma, that may need to be on opioid medication for the remainder of their lives in order to have good quality of life, because chronic pain, it can be devastating. So don't be afraid if your doctor or your nurse practitioner gives you a prescription for something for pain. Very, very unlikely that addiction will be an issue. What we do when the patient no longer needs that medication. So let's say a patient goes for kyphoplasty due to vertebral fractures, everything's healing up. We don't just stop the medication because that's a little hard on the body, but we just slowly titrate the dose down until the patient is either on a very low dose or is off completely. So don't ever worry if you need something for pain. You want to take advantage of the science that's gone into pain medication. I'm a grandmother and a mother, and I would not hesitate to use appropriate opioid analgesics for anyone in my family if they were ill or in significant pain. Slide, please. So the next part of the presentation, and again, tonight is really from people that have asked to learn about specifically palliative care and medical assistance in dying. So I just want to take some time to talk about what palliative care actually is. Very often patients will get quite freaked out, significantly freaked out, when someone on their team suggests that they do a palliative care referral, because in people's minds it's like, well, if they're sending me to palliative care, I guess that's it. There's no hope for me, they're giving up on me, or whatever the patient might be thinking. And that's not necessarily true at all. Before I came to Princess Margaret, I was working at South Lake in Newmarket, and I was the palliative care nurse practitioner there. And I would see patients for years that were on the palliative care caseload. So it palliative care does not mean that someone is imminently dying or that the team thinks that something catastrophic is about to happen. So we always say that palliative care is really a holistic approach, meaning that we look at the whole picture. In medicine, the physician looks at one thing. The ophthalmologist is looking at the eye. The renal guy is looking at the kidney. They're not, honestly, you would hope they'd look at the whole picture, but they generally can't, because it's medicine's very complicated and they need to concentrate on their specialty. So palliative care, any sort of serious illness, and again, it does not need to be a terminal illness. And we do palliative care for children. We do palliative care for people in their 90s. And palliative care can take place in really any setting. So we have people receiving palliative care in their home, palliative care in hospital, palliative care in hospice, palliative care in long-term care settings. So it really treats not only the whole patient, but the patient and their family. So a palliative care team, it can vary on who's on it, but generally you're going to have doctors and nurse practitioners, registered nurses, social workers, spiritual care practitioners, and the palliative care team works with the patient's existing physician. They don't really take over care unless it actually is end of life, and that's really at end of life. So if you're referred to palliative care and you have multiple myeloma, you're still going to be seeing your myeloma team, but the palliative care team will be concentrating on the symptom management or whatever it might be that the hematologist isn't able to manage. Um, and one of the differences is that in palliative care, we're not necessarily so concerned about what is causing the issue, especially towards the end of life. More our concern is more what can we do to make that patient feel better. For instance, if someone has say recurrent infections, and one of the things that they experience is constant fevers, the palliative care team will leave the treatment of the infection to the other, their main physician. But the palliative team will say, okay, what can we do to manage these fevers to ensure that people are having generally a better day. Supporting the patient, but also their family members, whatever their family looks like. And family, we know, is not always blood family. A lot of us have friends that we certainly love as much or even more than our blood family members. So in palliative care, we want to include those people and answer their questions and support them. Again, especially as the patient becomes, if the patient is deteriorating. So palliative care services can be utilized during any stage of an illness, even when they are still on curative treatment. So if you take anything away tonight, remember that just because it may be suggested a palliative care referral doesn't mean that treatment is going to stop necessarily, or that's what the myeloma doctor's thinking, but they thought they better get palliative care in first. That's not necessarily, it's not true. The palliative care team will work together with the myeloma team to help manage those symptoms, whether it be pain, whether it be depression, whether it be anxiety, whether there's end of life care planning, etc. We're going to, on the next slide, we're going to talk about, or the next couple of slides, talking about planning for end of life. And I recognize that most people on tonight are this is again uncomfortable, but it's so important that we do have a plan in place. And it's not for us if we're dying, it's for the people who love us. Slide, please. So interestingly, I had a 44-year career, which I'm missing terribly. And palliative care, when I first started nursing, it was almost like people thought of it was sort of like witchcraft. It was really shunned, and nobody really wanted to talk about it. It really is, even now, years and years later, it can get a really bad rap. But over the last 20 years or so, there's been much research done showing conclusively that, and consistently, the patients with life-limiting illnesses that have early palliative care involvement have a better quality of life and often live longer. And there's been a lot of these studies have been in solid tumor medicine, or in neurological diseases such as ALS or supranuclear palsy or Parkinson's disease. But regardless of the illness, it consistently shows that people have better quality of life. I think just having that extra support goes a long way. Having someone else to ask questions of and talk to. I just dropped on this slide, one of the studies that was done back in 2010, and so this is 14 years ago, and it got a lot of talk when this came out. Excitingly, before I left Princess Margaret, we're going back now over 2 years that I started working with the palliative care team at Princess Margaret. And then I retired, but they're starting finally at 2.5 years later to bring in patients with multiple myeloma to examine efficacy of early palliative care specifically for this disease. And I know in my heart that it's going to be a great benefit to patients because it'll take some of the stigma out of what palliative care is and who the people are that do palliative care. We are a little odd, I guess. It's an interesting career choice by far. But I'm really I went to myeloma rounds at Princess Margaret last week, and it's finally getting off the ground, and they're going to start accruing patients now for newly diagnosed myeloma patients or myeloma patients that have had recent relapse. So it'll be very exciting over the next couple of years when they publish the results. Slide, please. So when I would talk to people in my role with myeloma about planning for end of life, a lot of people were just sort of shocked that I would bring it up. But I always say that if we don't plan, if we don't have a plan for a big event, it generally doesn't go swimmingly well. I mean, you would very few people will plan a wedding in a day, or it's there's some things that need to be looked at and discussed with family members, etc. And one of the first questions I always asked was, well, where would you like to be at the end of your life? And we really only have three in Ontario at this point, three areas where patients can die. And I apologize if the word die is upsetting to people, but that's the word I use. We can either die in an acute hospital or in a residential hospice, and we do not have enough residential hospices in Ontario at all. Most residential hospices only have 10 beds. I live in Burlington. I'm sitting in the beautiful town of Burlington right now. I forget what our population is, about 170,000 people now. And we only have 10 beds for our hospice. And then the other idea is at home with supports from home care. Unfortunately, we know that over the last decade plus, healthcare has become increasingly stressed. And if you think people are working short in hospitals, they're really working short in the community. So it is getting more and more challenging to die at home, unfortunately, because, when I was a palliative care nurse before I went back to school, and I could go and see my actively dying patients twice a day. And now the palliative care nurses might get in to see the patient twice a week. So it's challenging at home. So these are the discussions that you have to have. Difficult discussions about, CPR, cardiopulmonary resuscitation, what that is, what it means, what happens. It's not like it is in the movies by any means. Do you want to be admitted to the ICU? Would you want to be on a ventilator? All of these things need to be discussed. Because if we don't have these discussions, then our loved ones then have to make the decision. And it can be very, very, very difficult if you haven't sort of said, listen, if something happens, this is what I want. I don't want to be in the ICU. And I'm not comparing my situation to anybody online with myeloma, but I'm having a knee replacement in 2 weeks. It happened quite suddenly. And I phoned my son today, who's a soldier in Trenton, and I just reiterated once again, this is what's happening. I have a 4% chance of dying on the table. That's the statistic. Do not put me in the ICU. Do not put me on a ventilator. So if something catastrophic happened, he at least knows that's what I wanted, and it would be easier for him to make those decisions. Is there a power of attorney? People don't necessarily have powers of attorney in place. Slide, please. So a lot of patients would tell me, oh yeah, I have a will. Well, a will is not a power of attorney. And a power of attorney is in play before a patient dies. A will only comes into play after we die. So a power of attorney is very, very, very important. Within the power of attorney, you choose your power of attorney for either personal care or property. Tonight, I'll just really talk about personal care. Because if you have a power of attorney and you haven't told them what you want, then again, they're left in the lurch. The will, power of attorney, it's worth going to a lawyer and ensuring that things are sort of, all the I's are dotted and the T's are crossed. You can upload a power of attorney kit from there's a website here, which is Dying with Dignity Canada. There's lots of great information on this website. You can upload power of attorney packages. They are legal if they're witnessed, but if you're in a family where there might be some challenges, you have an estranged in-law or outlaw that's suddenly going to arrive and try and take over, it's good to have an actual legal document. Slide, please. So again, being proactive, as difficult as these conversations are, it's far better than being reactive. I read this, I found this sort of description of what planning is. And planning is really a human thing. Although I think some animals do plan, they plan their evil deeds. My cat just jumped on my lap. But as humans, we have the capacity to think ahead. And, it's been said that it's a prime mover in human evolution, because anything can change with our health in a heartbeat. People can be moving along, whether they've got an illness or not, and something happens, they have a fall, or they get an illness or whatever it might happen. And if they haven't had any planning, it really leaves family members in a bit of a state. If things change and suddenly there's a turn within for the patient with myeloma, where there's no further treatment available, or the patient says, I've had enough, I don't want to keep coming to hospital, or I don't want to keep having treatment. And it does happen, and that's okay. Palliative care, it takes a while to set it up. It really takes a while to set it up, especially at home. So again, you want to have these conversations early on with your family, as difficult as it may be. I mean, my family is pretty weird. I've been talking about death and dying since my children were toddlers. I talk about it quite easily, and I personally think it's a good thing. When my mom died, my grandchildren took it in stride, and we have conversations. And now my dad is quite elderly, so it's we all die. It's a fact of life, and it's something I think that would be good if we did talk about it. The sort of dying with dignity for me, especially if I knew I had a life-limiting illness, dying in a crowded emergency department on a stretcher where the staff is busy and don't know me from Adam, or dying in the back of an ambulance. To me, that's not death with dignity at all. I've already planned. I know exactly what I want. I've had conversations with my kids. I'm relatively healthy. I am healthy. I'm only 65, but things could happen. And again, I think it just makes things easier. Not necessarily for me, but for them. Slide, please. So the remainder of this evening, I'm just watching the time because I always go over. There had been some questions about what medical assistance in dying is, and we refer to it as MAID. And again, anybody that's not comfortable with this conversation is certainly, you don't necessarily need to stay on, but it's interesting. It's something that we do have legislation for. Medical assistance in dying occurs when an authorized doctor or nurse practitioner will administer medication that intentionally brings about a person's death at that person's request. There is eligibility criteria, which is very stringent. MAID became legal in June of 2016. I proudly say that I was one of many clinicians across the country, and not necessarily just medical clinicians, but people in legal capacity, etc. We worked together in order to have this legislation passed. Because since MAID is now legal, it means that the Canada's Criminal Code will now exempt doctors and nurse practitioners who provide or help provide medical assistance in dying. There are still many people, even those that provide palliative care, that are quite opposed to MAID, and that's okay. That's okay. Not everybody has to have MAID by any means, but the fact that it is available for patients that are eligible, and it's appropriate for them, it's been a wonderful thing. Slide, please. So eligibility, again, it's very, very strict. Patients must be at least 18 years old and competent, and competency will be determined by their medical team, sometimes by psychiatrists. If there's any question about competency for whether they're 18 or 72, it's investigated. Patients must have a grievous and irremediable medical condition. Now, this does not necessarily mean people think that you have to have a terminal diagnosis in order to have MAID. That's not true at all. If you have a grievous condition that is affecting your life in such a way where quality of life is so unbearable, then that patient may be eligible for MAID. A patient must make a voluntary request about MAID. If the MAID team determines that MAID was suggested or encouraged by a family member or a friend or a medical someone on the medical team, that patient will not be eligible for MAID. It really needs to come from the patient. Again, this is why we need to talk about these things, so that patients know, that Canadians know that this is available. Patient must give informed consent. Interestingly enough, there's been a lot discussion about mental illness, and mental illness is not necessarily determined as a terminal illness, but having schizophrenia or bipolar disease, or other various mental health issues can be so devastating. And we have just heard, it's still a ways away, but as of May 17th, 2027, patients with mental illness and no physical illness will have the opportunity to request MAID. And if they're eligible through the eligibility criteria that will be set up for mental illness only, they will be able to move forward. Slide, please. So there's a lot of safeguards. I mean, we want to make sure that this is taken seriously, and that people are very careful. So again, a patient will make an initial request to either their physician or nurse practitioner. That request will then be signed by an independent witness. So that's the first piece. So the initial request, and then the independent witness. So if someone asks me about MAID, and so the request has come in me, then I'll have someone else that's not involved sign the request. Then there are two independent medical assessments. The assessors must not know each other. So there can be no, those two assessors can't work together or know each other, and this will prevent any sort of chit chat back and forth. Well, I thought, no, it's a very clear cut. It's a list of questions, and the two assessors do not cross paths. The other thing is that, this is obvious, but it's in the legislation, that the assessor cannot benefit from the patient's death, meaning that, I mean, it could happen if Bob Smith or Joe Blow is leaving money to a charity in the name of the assessor, that would be considered inappropriate. Patients can withdraw or change their mind at any time, and that includes up to the second that the medication is administered. So sometimes patients, they think this is what they want, they go through the procedure, but at the last second, they just think, you know what, I don't want to do this. This isn't feeling right. Just before the medication is administered, the patient needs to verbally consent again. Now, an exception to the rule is if the patient is too ill to consent right before the administration of the medications, the physician, if the physician or nurse practitioner, because it'll be either or that's actually giving the medication, if that, so let's say I was the administrator of the nurse practitioner in the room, if I had many conversations with that patient leading up to that day, then and I felt very confident that things have changed, patient's now not able to consent again, but I feel that I'm very, very confident in my professional ability that this patient is would want to continue. There is a 90-day, and I forgot to put this on a slide, I apologize. There's a 90-day wait period for most patients requesting MAID, and that is to give patients the opportunity to really think about it and change their mind if they want. Now, if patients' clinical situation changes and quality of life is deteriorating quite quickly, they get in touch with the team and say, listen, things aren't going well for whatever reason. I have no appetite, or my pain is bad, or whatever it might be. And quite often, then the 90 days won't need to pass. The team will decide that it's okay to go ahead at whether it's 5 weeks or 4 weeks or 10 weeks or whatever it might be. So again, there are many, many, many safeguards that were put in place. So no, when this was developed, it wasn't done without great forethought and significant discussion. Slide, please. So at this point, the majority of medical assistance in dying is actually happening in people's houses. There are certainly families that aren't comfortable with this, and I understand, having someone and their life in, in their bedroom. But a great many patients decide that that's where they want to be. It does happen in hospitals. Sometimes the palliative care unit will have a room that they use for MAID. It can happen in hospice. It can happen in long-term care settings, etc. And again, it's a separate team from the team that normally works at that hospice or long-term care setting. So again, as I mentioned, again, this is really, really important that at any time the patient can change their mind, literally until the drug is being infused. And um, it doesn't happen often, but I have seen it happen. There are 3 separate drugs that ensure efficacy and comfort. I can say without reservation that during this procedure that patients feel no pain, no distress, no shortness of breath, no restlessness or agitation. It is as peaceful as could possibly be at end of life. The medications currently in Canada are established by the individual provinces and territories. In Ontario, these are intravenous medications, so they're on board quickly. So in Ontario, we're using midazolam, which is a medication we use for anxiety. So the patient is given the midazolam first, and it just sort of lets them drift and chill out and be very, very peaceful. And if they were having anxiety, that anxiety will be lifted. Then propofol is infused, and that is used to put the patient into a coma. And those of us that remember Michael Jackson, unfortunately, that was what he was being administered at home. He was getting propofol intravenously in his bedroom to be able to sleep, which was really quite silly because when you sleep in a coma state, you're not actually sleeping, so you'd still be tired. And then rocuronium is a neuromuscular blocker. So, I didn't finish my parentheses there. This will now stop the diaphragm from lifting. So respirations will stop. And after a period of time, when the respirations stop, then the heart will stop. And again, especially people that have claustrophobia, the thought of, not being able, or the thought of someone we love not being able to breathe, it's so just so somewhat really distressing to think about it. But again, I've been with numerous patients at end of life when they have MAID, and there's been many studies done using EEG monitors and ECG monitors and feedback things that patients do not have that feeling like I can't get my breath, like why can't I breathe? They do not experience it. They're already sound in a coma-like state, and it's very, very peaceful. And that's why we use those 3 medications, and that's why we put them in first the midazolam, then the propofol, and then the neuromuscular blocker. And on Ontario, there are 2 other neuromuscular blockers apparently that are being used right now. But the point being is that a neuromuscular blocker is the 3rd drug that will go on board. Slide, please. So IV medications, they really take effect really quickly. As soon as the midazolam's on board, patient will become very, very sleepy. And then once the propofol is infused, the patient will absolutely not be responding anymore. And then the neuromuscular blocker will be put in 3rd. Generally, death occurs within 10 to 15 minutes of the 3rd drug going in. There have been cases where patients have lived longer. Um, It's not often, but it could happen. But again, the important thing to remember is that patient, even if they haven't died yet, um, that they're not suffering. And when we love someone, we don't want any suffering. Uh, MAID is covered under our provincial healthcare plans. So all of the medication is covered, all of the visiting team, all that is paid for. If people are sometimes worried if they have life insurance policies that it'll be null and void if you choose MAID, that's not true. The insurance policy of that patient will still be intact. So if they have a life insurance policy and they have MAID, their beneficiaries will still receive the funds from that insurance policy. So in June of 2016, we had our first MAID cases across Canada. And the latest statistics that I could find was between June of 16 and then the fall of 2022. And so that's almost 2 years ago, but the latest numbers aren't available yet. But even between 16 and 22, for over almost 45,000 Canadians were able to die with dignity, the way they wanted to die, peacefully, receiving MAID. Again, it's not for everybody, without a doubt. It may be because of religious underpinnings. There's so many reasons that people would choose not to have MAID. But for those patients that have a grievous illness and feel that their quality of life is just unbearable to them, and I'll give you a hint, if any of you online ever choose to have MAID, during your interview with the assessor, never, ever, ever say, I don't want to be a burden to my family anymore, because they might disqualify you. It has to be about you as the patient and not about being a burden. So that's just a little hint. And I wanted just to point out, obviously I believe that MAID has its place in society. But I'm also, working with CMRG. So I obviously believe that research and treatment is very, very important. So even though we have access to medical assistance in dying, it has not changed at all in any setting, whether it's myeloma or breast cancer, glioblastoma, whatever, that, our researchers and physicians continue to work diligently to find a cure for these really, really challenging and devastating illnesses. I know, and I'm very hopeful that the work being done here at CMRG for you, patients and family members of patients with multiple myeloma, hopefully MAID will be something that you never have to consider, because, as Dr. Reese and all the other researchers in the world work towards a cure for myeloma, I hope for everybody online that MAID for myeloma isn't something that you have to entertain. Slide, please. So I know that this is certainly a sort of a heavier, sometimes more emotional talk than learning about the new treatment modalities that are coming, but I'm certainly open to answer any questions. Again, if there's something you would prefer to talk privately about with me, I can be reached at, you can email me at srowland, SROWLAND at cmrg.ca, and I will certainly get back to you if it's something that you just don't feel comfortable speaking out loud. So Ellis has his hand up first, and then Robert. You're muted, Ellis.
Oh, yeah, okay.
Hello.
Hi, how you doing?
Good, how are you?
You are a ball of fire. What a great, provocative presentation.
Oh, I'm glad. Thank you for that.
Yeah, I really enjoyed it. My question is, in order to make a decision, if we're going to make a decision to experience palliative care, who who calls the shots? Is it our hematologists, oncologists who usually say, hey, you know what? I could only take you so far. I want to now send you to palliative care to combine some of my efforts with their efforts. Do we on our own? I don't know how we would on our own decide it's time to sort of combine the efforts of palliative care and our medical care. How, when, and how, and most importantly, who, with whom do we make a decision? Hey, you know what? Palliative care plus my hematologist, oncologist, that's the way to go.
Yeah. Well, I hope that this talk will help you feel ballsy enough, that's a bad word, I guess, brave enough to bring it up to your team. And if you have questions about what could be coming down the road, or if you have symptoms that you don't feel are being managed enough to your liking, there's no reason that you can't ask for a palliative care referral. Now, sometimes your hematologist, oncologist might get their back up a little bit, because then they start worrying, because a lot of doctors aren't comfortable with the idea of palliative care. But the more we talk about things, and you can just say, I want to talk with someone in palliative care because I want to, we need to update our powers of attorney, or we want to have I want to learn more about what palliative care is. And certainly and you know what, if your hematologist, I hope it wouldn't happen, but if they're not comfortable making that referral, I would talk to your family doctor without a doubt, or the nurse practitioner in your practice.
But it's not always necessary. I mean, if we're comfortable with our
Yeah,
oncologist, hematologist, would you say, hey, just stay there?
I think if it's status quo and disease is stable and you're not
Yeah.
having any symptoms. That being said, I still would highly encourage you to look into ensuring that your power of attorney is up to date, and that you have chats with your family, just in case something happens. I mean, I'm just having a knee replacement, and I've been very clear what will and will not happen if something catastrophic happens during the operation. So, but you're right. I mean, if you don't need palliative care right now, that's okay. Robert. Hi, Robert McCaw.
Hello, Suzanne. Thank you for a wonderful presentation.
You're more than welcome.
As part of a member of the steering committee for our Toronto group, we are toying with this idea of having a presentation. It's very important, so thank you. My specific question is, you caught my interest when you said there's a study coming soon on early palliative care for myeloma patients at PMCC. My question is, would the study also be available for, well, an example of me? I'm not a current active patient at PMCC. The only time I go there now is for the walks, but I'm active at Southlake. So will it become available to other cancer centers in, say, the GTA?
So as far as this particular study, it is definitely just being done at Princess Margaret, and the numbers of patients that they're going to accrue aren't even going to be that many. What I would do though is, when and hopefully we will still be seeing each other down the line when the when the data is published, and then you can take it back to whomever is at at Stronach there, and say, this is I mean, there's a great palliative care team at Southlake. I at least it was good back in the day. But yeah, for now, this is definitely a Princess Margaret study.
Thank you.
You're welcome. Thank you. Ms. Ramdas, how are you? You want to talk later? You got your hand up though. I can't hear you. You may be muted. Doesn't look like you're muted. Why don't?
Can you hear me?
There you are. Now I can hear you. Yeah, go ahead.
Hi, Suzanne. Sure, we can speak later because it's several questions. It's not one.
Sure.
So I'll give someone else the chance. Thank
Okay.
you.
Okay, thanks. Hi, Geraldine. How are you?
Oh, I'm good. Thanks for a great presentation.
You're more
Yeah.
than welcome.
So I have been dealing with chronic pain for a
Yeah.
number of years. And I went to my family doctor and asked about palliative care. And she said I would likely get rejected because in Ontario, they only accept people from six if they have 6 months or less.
Well, that's wrong. Where are you being treated?
Well, I'm being treated with my hematologist in Oshawa.
Yeah.
My family doctor is in Port Perry.
Yeah. I mean, I'm sure that, wow. So there's a, you know, there's a big misconception about, again, what palliative care is. And it really just isn't for end of life. And I would speak to the team in Oshawa and not give up, because you know, end of life care is only a portion of what palliative care is. And I've had, in fact, I've worked with a team in Oshawa, both the community palliative care team and the Oshawa, you know, the team in the hospital. I would not give up. I would not give up. Absolutely not. I would, excuse me, I would go and speak to your team in Oshawa and say, listen, I'm really struggling with pain, and I really like to see someone from palliative care. I'm sorry you're going through that.
Okay, thanks, Suzanne.
You're welcome. Anybody else with questions? Okay, I guess that's about it. I suddenly have got an empty spot in my brain. I can't remember right now what the next seminar is going to be, but it will be on the website. Please continue to utilize the CMRG website. Tell your friends that we're here. And hi, David McMullen, I just saw you. Again,